Welcome to the fourth and final module on perioperative chest X-ray interpretation for anesthesia providers. This module will cover recognition of pathologic findings. The objectives and aims of this module are to identify acute pathologies that may be anesthesia-related, including pneumothorax and negative pressure pulmonary edema, and to identify common pathologies that may impact anesthetic approach, including atelectasis and cardiogenic pulmonary edema. This module is not intended to direct diagnosis based on chest X-ray interpretation. A simple pneumothorax occurs when air enters the pleural space, separating the visceral pleura from the parietal pleura. Air is visible between the visceral pleural lining and the rib cage. Radiographic features of a simple pneumothorax include a thin, sharp white line which represents the visceral pleura, no long markings visible past the white line, no mediastinal shift, and partial or complete collapse of the affected lung. When air enters the pleural space and cannot escape during expiration, intrapleural pressure increases, leading to compromise of mediastinal structures and attention pneumothorax. Attention pneumothorax has the same radiographic features as a simple pneumothorax, but with a contralateral shift of the mediastinum, contralateral tracheal deviation, and a depression of the hemidiaphragm in a caudate direction. Additionally, the deep sulcus sign may be present. The provider notes a deep sulcus sign when an acute, well-defined costophrenic angle is visible on the side ipsilateral to the pneumothorax. This phenomenon occurs secondary to hyperinflated pleural space. The chest X-ray on the left is a multi-trauma vehicle accident. Notice the obvious pleural border where no pulmonary vasculature is evident beyond this point. There is no mediastinal shift. Also note the presence of subacute air on the right chest wall. The chest X-ray on the right is a 10-day-old neonate with bilateral pneumothoraces. Notice the pleural borders on the right and left, the deep sulcus sign bilaterally, and the lack of mediastinal shift. It is important to note that this chest X-ray has the features of simple pneumothoraces, but due to the bilaterality of the insult, absence of mediastinal shift does not rule out tension pneumothorax. Now let's look at tension pneumothoraces. The chest X-ray on the left is an intensive care unit patient with an endotracheal tube and a left-sided central venous catheter in place. The central venous catheter was placed 2 days prior to imaging and is not thought to be the cause of the tension pneumothorax. The patient did require high pressures on the ventilator, which clinicians surmised likely resulted in spontaneous right lung collapse and subsequent tension pneumothorax. Let's apply some of the skills we've practiced in previous modules and examine the features of a tension pneumothorax. Note the left-sided central venous catheter with proper positioning. The left lung border near midline, leading to a complete collapse. An endotracheal tube is in place and the trachea is deviated to the left. There is a complete leftward shift of the heart, and a deep sulcus sign is present on the right. On the right, we have a left-sided tension pneumothorax. This is a 20-year-old male who presented to the emergency department with a complaint of shortness of breath after experiencing a pop and left-sided chest pain the day before. Note visible lung border with no vasculature beyond the pleural edge. The cardiac silhouette has shifted midline, and the trachea is deviated to the non-affected side, indicating a mediastinal shift. Note the absence of the deep sulcus sign. This chest X-ray was taken with the patient in the upright position, which may shift the intrathoracic pressure downward versus an image taken in the supine position. Notice the diaphragm on the affected side is flattened due to this ipsilateral increasing pressure. Negative pressure pulmonary edema is an acute process that occurs when a patient with a closed glottis generates sudden increases in intrathoracic pressure. In anesthesia, this usually occurs during or shortly after tracheal extubation. Patients who are young, lean, and muscular are at higher risk of experiencing this phenomenon because this population has the physical strength to generate the high intrathoracic pressures necessary to result in intrapulmonary fluid shifts. Chest X-ray features include diffuse hazy bilateral infiltrates in the perihilar region. These infiltrates often take on a bat wing or butterfly pattern. This is an example of negative pressure pulmonary edema or post-obstructive pulmonary edema due to laryngospasm. Notice the butterfly or bat wing pattern of edema. Also notice that this patient appears to be lean, which is consistent with a higher risk population for this pathology. The last chest X-ray on the right was taken of the same patient 48 hours after the initial imaging. Notice how easily the cardiac silhouette can be visualized due to overall resolution of pulmonary congestion. Cardiogenic pulmonary edema is the result of left-sided heart dysfunction or failure leading to fluid buildup in the lungs. Conditions associated with cardiogenic pulmonary edema include left-sided heart failure, hypertension, ischemic heart disease, coronary artery disease, cardiomyopathies, and fluid overload. Radiographic features consistent with cardiogenic pulmonary edema are an enlarged cardiac silhouette, interstitial edema, pulmonary vascular congestion, pleural effusions, whiteout or butterfly fluid pattern, and curly B lines, which will be discussed in the following slide. This chest X-ray is of a 75-year-old female with a history of myocardial infarction and dyspnea. Notice the cardiac silhouette is more than 50% the width of the thorax, indicating cardiomegaly. Pulmonary vascular congestion is also present. Curly B lines, also known as septal lines, indicate interstitial edema. They appear as thin, horizontal white lines that make contact with the edge of lung fields. Curly B lines are radiographic indicators of pulmonary hypertension and are usually not present until the patient's pulmonary capillary wedge pressure reaches 20 to 25 millimeters of mercury. This chest X-ray is of a 40-year-old male with a recent diagnosis of acute renal failure experiencing shortness of breath. Before looking at the anatomic features of this radiograph, take note of the number of the EKG leads on this patient. And there appear to be more posterior and to the patient's left. If you're examining a chest X-ray on a patient and there is limited background information available, just noting features like this 12 lead can clue you in to what to look for or what symptoms the patient may have been experiencing. Now, let's look at the features of this chest X-ray that suggests cardiogenic pulmonary edema. Note the cardiomegaly with the cardiac silhouette accounting for more than 50% of the width of the thoracic cavity. Interstitial pulmonary edema as evidenced by curly B lines. Bat wing or butterfly vasculature pattern. Also note the blunted costophrenic angles. Directly beneath them is what appears to be an elevated diaphragm. This isn't the true diaphragm. Instead, it's a fluid collection in the pleural space indicating bilateral subpulmonic pleural effusions. This pathology is only apparent in the upright position due to the gravitational shift. Also note the distance between the gastric bubble and the pseudodiaphragm. This is a common feature that aids in identifying left-sided subpulmonic effusions. The top right chest X-ray serves as a reference for normal distance between the diaphragm edge and the gastric bubble. Atelectasis is a major cause of perioperative morbidity and describes the incomplete expansion of lungs. Alveoli are unable to fully inflate and cannot effectively participate in gas exchange. The incidence of atelectasis in surgical patients is nearly 90%. Clinicians may see hypoxemia and decreased lung compliance in patients with pre-existing atelectasis. Clinically relevant risk factors for atelectasis include anesthesia administration, use of muscle relaxants, inadequate pain control, thoracic or cardiopulmonary procedures, pneumonia, and obstructions such as foreign body aspiration, mucus plugging, and tumor. Radiographic findings indicative of atelectasis include displacement of lobar fissures on affected side, opacification in the collapsed segment, slight ipsilateral mediastinal shift, and an elevated ipsilateral hemidiaphragm. The image on the left is a 35-year-old male that presented 1 week post-splenectomy reporting chest pain. Note the elevated diaphragm bilaterally. Bilateral atelectasis evidenced by the areas of central consolidation. Notice that this does not follow the broad diffuse butterfly pattern seen in pulmonary edema. On the right is a 45-year-old female scheduled to undergo an elective procedure. The patient developed bradycardia and hypotension after anesthesia induction. Airway pressures increase progressively with concurrent decreases in pulse oximetry values. This patient coded, and this is the post-resuscitation chest X-ray taken upon admission to the ICU. Of note, this patient has some sort of pre-existing condition requiring an implanted device, possibly a deep brain stimulator. A right internal jugular central line, diffuse opacities of the left lung. So what happened? A right mainstem intubation. The endotracheal tube was withdrawn, and subsequent chest X-rays revealed resolution of atelectasis and no pathology of the right lung. This concludes the final module. We hope you found this forum helpful.